Welcome to Colorectal Surgery Virtual Education Series. We have Dr. Beth-Ann Shanker and Andrea Torok with us tonight. I'll quickly introduce our guests. Dr. Shanker grew up in Philadelphia. She attended the University of Rochester, earning both an MD and Master's in Science in the field of HPV. She completed her general surgery residency at Rutgers University in 2013. After graduation, she moved to Orlando for an Advanced Colorectal Surgery Fellowship, followed by Colorectal Residency. She's ecstatic to be a part of the Trinity Health Ann Arbor family and serves as the Associate Program Director for the Colorectal Residency. Her clinical interests are robotic surgery, complex anorectal surgery, and pelvic floor pathology. She developed the curated fellowship program at Trinity Health, which is tailored to each trainee's professional goals, wellness, and provides professional coaching. Miss Andrea Torok has been a Michigan resident most of her life. She graduated from Michigan State University with a degree in psychology prior to obtaining her nursing degree in 2003. She has been certified in wound and ostomy management since 2006. She's currently employed with Trinity IHA, colon and rectal surgery, as a wound ostomy nurse. Andrea has worked in several settings, including inpatient, outpatient clinical settings, wound centers, and in the field as a wound ostomy nurse. She also functioned as a nurse educator in wound and ostomy management for Trinity Health, working with nurses, families, and patients in management with difficult stomas and strategies to maximize independence for the patient. Andrea was most shaped by an assignment at Billings Clinic Hospital in Montana in 2010. She worked with Native American and indigenous populations to help creative resources and effectively teach patients with limited resources and significant comorbidities. Thank you both for joining us. Dr. Shanker, take it away.
Thank you.
Are you, thank you for the nice introduction. I'm ready to just hear Andrea talk. Are you still able to see my screen?
Yes, we can see your screen. You can go to, the PowerPoint. Perfect.
All right, sounds good. So again, thank you for having us. This is a picture of the hospital, Trinity Health, that we work at. This is Trinity Health Ann Arbor, located in Ypsilanti. And it looks like here like a giant parking lot, but there's other buildings there besides the tower. Mind you, we are in Michigan, and I promise you this picture was not taken in February. So the goals of this talk, before we started, I had said the goals of this talk was that we would talk about all the problems I created in making a stoma and all the way that Andrea fixes them. So that's sort of the simplified version. But we're going to talk about managing a complicated stoma. You know, what can go wrong? What makes the stoma a challenge? You know, from creation to early complications to late complications. What are the different types of stomas? How do you standardize documentation of your stoma and the care? And what are some examples of complications of intervention? All right, you are probably familiar with this from the ASCARS textbook, this chapter was written by my colleague Mike McGee at the University of Michigan. These are common complications. What's interesting when you see charts like this, you see a huge range. So most complications are kind of well captured in the hospital for national quality databases. But when the patient leaves the hospital and becomes an outpatient, it's much harder to capture these complication rates. So you see these wide ranges reported. So you see retraction, peristomal hernia, stoma prolapse, necrosis, peristomal skin problems, and total complications ranging anywhere from no percent to 70%. And probably the reality would be probably about 50% of people with stomas have some issue that needs to be addressed. Here are some images depicting some of these problems we're going to get more in depth about. Stoma prolapse, mucocutaneous separation, stomal varices, peristomal hernias, necrosis, pyodermic gangrenosum, fistulas. Now, I have yet to see a fistula with googly eyes, I admit it. This is from a blog, Thomas the Stoma, and from a lady living in the UK. And if you look at social media and on the internet, there is not a lot of education from like institutions or societies that go into depth for patients with specific problems, but people have sort of reached out and created their own platforms and blogs as a way that people get information, which is great for community, sometimes not always accurate information. So anyway, I really liked her blog, Thomas the Stoma, and of course I like that image. All right, and stenosis and retraction. All right, what are factors that lead to a difficult stoma? Why and when an ostomy is created, patient factors and type of ostomy can all lead to issues in stoma creation and care. So emergency stomas, obviously when we're doing an emergent surgery, the person may not have time to deal with care nurse beforehand for marking or for education. And you're also talking about an emergent situation where they may have unforgiving anatomy. Shortened mesentery. We've learned a lot about mesentery as an organ over the last 10 years. During acute events, times of inflammation, it has its own cascade of inflammatory markers. It gets swollen, it gets shortened, makes it more challenging during an operation to bring up an ostomy, as obviously the ostomy itself is tethered to the mesentery and its blood supply and edema. Even if an ostomy nurse can see somebody going to an emergency surgery, you have change in morphology, distension, other issues that make it difficult to mark. With an elective stoma, not only do you get somebody maybe with their normal belly or close to normal belly, but we have time to modify some risk factors, uncontrolled glucose, cigarette smoking, depending how long it's going to be stretched out for, some weight nutrition management to optimize that. But another thing that we don't specifically address here is that patients have time to learn about ostomy care beforehand, which is a big mental health barrier. I think all of us have come across those patients who refuse an ostomy or don't want, obviously don't want one. And they have really time to get that education and receive information on undergarments, exercise, sexual activity, I think, which plays a role into mentally preparing them for it and also getting them ready to take care of themselves afterwards. All right, patient factors that contribute to a difficult stoma anatomically are obesity. This may include an ostomy in the lower quadrant where the lower part of the abdomen, the pediculi is thicker and the abdominal wall is thicker, so it can be harder to bring an ostomy through that. You may be more reluctant to if you think that'll make it harder to reverse if you're planning on something temporary. Previous abdominal surgical scars, contours, bony prominences. At previous surgeries, I have a patient tomorrow who had some sort of reconstruction for breast surgery she couldn't remember, and it seems that she's had some sort of translap or reconstruction with her left side of her rectus muscle. So, that was, playing detective and figuring that out for surgery so you can make decisions. And again, talking about their mental health and being prepared to deal with that aspect of it as well. The types of fecal elimination for a colostomy, we're creating over 120,000 a year. The end colostomy can be a temporary or permanent fecal diversion. The loop colostomy is more often thought of for temporary diversion, but of course can also become permanent depending on the situation. Loop colostomies can allow for venting of that distal segment if there's an obstruction or a blockage. Transverse loop colostomies can be the easiest to make, but have the highest rate of prolapse, more unsightly for the patient to deal with, may impact more on their mental health, and typically larger in that upper quadrant. For the ileostomy, this can also be permanent or temporary. Loop ileostomies more often we think of as temporary, but again can become permanent. There's a liquid nature to the output that can lead to more problems with pouching. We also want to think about your patient. If they have heart failure or kidney issues, and fluid status is really critical to their other health comorbidities that they're managing. You may want like a temporary diverting ostomy, even though, they both have pros and cons. It may be better with some fluid management there. The loop endostomy is where you divide the colon. Let's say you have your staple line over here, but for like inflammation or anatomy, you're not going to be able to bring up that end of the ostomy through the abdominal wall, and it becomes easier and less torsion on the ostomy itself for the blood supply, just to bring up like a knuckle of ostomy, several centimeters or more proximal to where you divided it. So that is an end loop, and when you mature it, it looks like a lobostomy. But you want to be aware of that that's actually like a dead end on the other side, and make sure you scope that and know that that's there. And loop is when you're bringing up your end and your mucus fistula through the same aperture. So it's essentially reverse that, like a lobostomy, through the same aperture, but again, it's completely divided. So other configurations of ostomies that we create. You also want to think about maybe creating a template or having a way between yourself, primary care doctors, other people like acute care surgery who may be also creating an ostomy. It can just make communication easier, and may let you know if you're seeing somebody who had a stoma created like 10 years ago, and is coming in with new problems, sort of what they had and what's going on. So the year and location of stomas created, where, if it was at your home institution, what surgery they had that led to the creation, and if it was emergency or an elective. Reason to create this stoma, you may see a stoma and think it's something reversible, but you want to be aware if they had neurogenic bowel or other issues that may then maybe have like physiologic dysfunction of their colon and what that was. If they have plans for reversal, you want to know that. And for your first meeting, you're going to collect all that information up front. I think if you're seeing somebody more on a continuing basis, you want to know if they've seen a stoma nurse in the last 12 months. If it's like a long-standing ostomy and they're starting to need to see somebody, it makes you think that something else could be going on there. And you want to really prompt them to know if there's changes in the stoma itself, such as bulges, retraction, difficulty pouching, bleeding, changes in their stool coming out of it. You want to record the last colonoscopy if they still have colon, or even if they still have rectum, their last sigmoidoscope, and you want to take a picture of that for documentation. We have a lot of studies, mostly in wound care nursing journals, that show that patients are really poor at reporting a lot of changes in their stoma that may indicate something else is going on. So there's many validated questionnaires they could fill out, like in the waiting area before they come in for an office appointment or in the hospital, regarding like bleeding changes, weeping skin, like new lesions, anything else that they're seeing that can help you figure out like why something's changed and what the underlying cause is. Regardless of the problem, you want to think about the patient. And so you want to think about the demographics. I have a patient who unfortunately was a no-show. She's in a domestic violence situation at home and has been in and out of some drug rehab. And right now she has not seen a lobotomy care nurse in a long time and is getting all her supplies from the emergency room. So it's sort of understanding the demographics of your patient. If you're creating a new ostomy, unless there's a real reason why they can't take care of it from a relationship and mental health standpoint, you want to really provide that person with support to take care of their own ostomy. There's a good amount of literature that show that people with ostomies are more likely to get divorced if they're married and or lose a relationship. And that if that partner becomes a primary caretaker of their ostomy, they're likely not to engage in a romantic relationship. And so that could be like a marker of other things obviously going on, but having that person feel competent and independent in their health care is important. And of course, you want to know nutritional status, BMI, smoking, all the other things that we want to know when we're taking care of stomas and they're having problems, and especially if we're thinking about a reversal. All right, we're getting to the important person. We're getting to Andrea here. Stoma complications, early or late complications. A lot of times in surgery, we think of early complications as within 30 days. But really, I think with a stoma, we're also thinking about whether or not they need to go back to the OR for revision. So we're really thinking maybe sometimes under 2 weeks in those cases. So an early complication would be like a mucocutaneous separation, stomal necrosis or ischemia, stomal retraction. Some of these things could just be non-emergent or emergent. Later complications, again, harder to capture that percentage or incidence in the population, but that's the stenosis, the prolapse, the hernias, and the abscesses and fistulas. So, what the complication is and how emergent it is a big aspect of managing stomas later. All right. So an early stoma complication, I talked about the mucocutaneous separation. We see it with diabetics, poor nutrition, people on steroids or chemotherapy are more likely to see this. And I'll let Andrea speak a little bit to how she manages or thinks about mucocutaneous separation.
Okay. Hello. Thank you. So when we manage this, we need to heal the area. It's separated at the junction away from the stoma. And so the big key is going to be absorption because that's considered a wound. Once we have a wound, we need to treat it like a wound. And so some separation is very minor. It can be treated with like a pectin powder, a skin sealant, but often we have to put a wound dressing in there. And the key is going to be absorption. We need to keep that drainage from them breaking the seal because then we have a lot bigger issues in the skin around it. So we always notify the surgeon right away about that just because there can be complications that follow that. So we always monitor that. Most of the time they heal without incident, but it's just something to always have on the back burner for your surgeon that, we have a separation. So.
So so severity of it, and then that local wound care. Stoma ischemia, you may be reported about like an ischemic or dusky stoma, and this could be hard to know, like what the person who may be calling you is actually seeing. If they're seeing like a plum-colored, sorry to ruin plums for everybody, a plum-colored stoma, it could just be venous congestion. And that's the most common thing we're probably going to see. The arterial flow is fine, but from the post-surgical situation, you're getting a lot of congestion. You may want to make sure that fascia opening isn't too tight. And if it was fine when you created it and is a little bit snug as the edema goes down, it's going to be just fine. But venous congestion, nothing really there but supportive care. But if they are actually having ischemia, you want to first assess the person and say, hey, is this person dynamically stable or not? Especially for a thicker abdominal wall, maybe you shear some mesentery bringing it through. If it is a really like focal area, that may be something you just watch and let slip off. But things you can do for a stable patient is at the bedside. I know we talk about the test tube test, but when I've needed to evaluate something at the bedside, like in an ICU patient, I would just bring in a gastroscope to look. Or, if they're stable on the floor, our GI doctors will ultimately just look with the scope to get an idea of the extent of necrosis or ischemia at maybe a CT angio. And for a hemodynamically stable patient, of course, you just want to know the extent of the ischemia, what their blood pressure and other factors are that are correctable, and decide if it's extending, beyond the fascia into the abdomen, if you're going to do supportive care, take care of the underlying problems, or if you need to go back to the operating room. When they're hemodynamically unstable, you want to think if there's something more catastrophic going on. If they're showering clots, is more the bowel viable or unviable or not viable? And that may be a case you don't have time to necessarily do this evaluation and just need to prepare the family that you're going to sort of be doing more of an exploration. But understanding the degree of the ischemia and underlying causes and thinking about your abdominal wall and how you pull that stoma through the abdominal wall. So for thicker abdominal walls to prevent shearing that mesentery off, we will typically put in a small wound retractor. Sometimes put a little lube on the inside of that wound retractor so that when we're bringing up the stoma, it's going through a lubricated surface, and we're decreasing our chance of causing some shearing in that mesentery. For retraction, early retraction, I had a gentleman, Steve, who had a kidney transplant, obesity, obstruction, other medical comorbidities, low ejection fraction. And he ultimately needed like a Hartman's procedure, sigmoid resection and ostomy, or palliative care. We had sort of all types of specialties involved with him and that decision making. He did go to the operating room. He did have pretty quick mucocutaneous separation being on his amount of immunosuppression and developed ascites. We had our in-hospital ward-ostomy care nurses help manage that, along with our hernia surgeons or our trauma team, actually. Ultimately, we had to take him back and recite him, but still had the same issue on the other side. And so with his comorbidities, that was issue we were worried about with the retraction. I have another example. I'll talk about that. I think I put this slide out of order, but it's never too early to talk about dermatologic issues. So these are common late complications with stripping and dermatitis and fungal infections we see. And I'll have Andrea, I think I'll have you speak to more how you manage these.
Hey, this is probably the number one, or this is the number one complication that we manage. So a lot of times when patients come to us, especially ileostomies, try to see them 7 to 10 days after discharge because of these issues. A lot of it is just, they're getting home, there's some operational error, things like that. But the big thing when we look at these, especially the dermatitis and also the candida, is that these moisture is getting on the skin. In the case of candida, it's of course causing fungal issues. So what we do in these instances is we use a powder, a pectin powder, on most patients. Every once in a while we find someone allergic to it. But drying up that moisture, if you use a pectin powder and a skin sealant, and you can see kind of around the dermatitis there's a white crust. That's what we do over all of the skin, so that when that barrier goes down, it'll stick nicely. The barrier is infused with pectin as well. So that will fuse together and help heal some of that. But they definitely need a different style barrier. And most of the time, it's really helpful if you can hook them up with an ostomy nurse who kind of can test the different levels of convexity. There's a lot to it, but it's always helpful to have somebody who can differentiate between candida, dermatitis, and then that bottom one is that epithelial stripping from taking that pouch off. We spend a lot of time focusing on how to remove a pouch in addition to putting one on. So,
Andrea, I'm curious, can you tell a lot from photos that patients send you in the chart? I'm thinking about our patients who live far away and may not have access to somebody. Is that a limitation for, it's a limitation, obviously, but how helpful are photos for you?
Yeah, it's of course a limitation for patient. It's always nicer to be able to come in and actually practice and do these things. We have a wide variety of different pouch barrier styles and product manufacturers. But one thing that we can do is, because people do want to come from far away to see Dr. Shanker, so sometimes we actually will do, we can talk over the phone. Every manufacturer of these, the products, so pouches, all of the accessories, you're able to actually call those, where the patient can call those manufacturers, and they actually have certified ostomy nurses right there that will help them and say, it sounds like you need a convex barrier. So they'll send them those, or we'll call and we'll tell these manufacturers what we want sent. And then we can talk to them later once they have the product and kind of go through step by step what they can do. And, patients don't believe us, but it is huge life-changing thing when you can sleep all night without worrying about getting stool all over your clothes and bed. So,
yeah, I wasn't aware that they had ostomy nurses also as part of the thing.
yes,
That's fantastic. Yeah.
yes.
All right. Let's move on to my slide. There we go. All right. So other late complications include prolapse. This is again, I create the problem and Andrea manages the problem. This is Bridget. She had Crohn's disease of the terminal ileum, a surgery I did with Dr. Diaz. She had declined treatment and her disease progressed, ultimately leading to being admitted to the hospital, being malnourished, being on steroids at TPN. And she was not improving, and ultimately we had to take her to the operating room. So she had a robotic converted to open ileosigmoidectomy, takedown of her iliosigmoid fistula, sigmoid resection with anastomosis. And so she had the end loop. So she had, through the same apparatus, an endoileostomy, and then the mucous fistula portion was her right colon. The plan was to manage her, and close her with a Cone-OS after she received Crohn's treatment and was in medical remission for a period of time. The risk for her developing prolapses, once we did the surgery, she had an excellent recovery, felt better, was in a surgical remission, able to start medication. She actually moved to New York City for a job. I came back for her Cone-OS procedure. But of course, once she could eat, she gained a bunch of weight. And at risk for prolapse, one include lack of bowel fixation, which is what we see with the small bowel, especially when we're making these ostomies. But also an increase in the size of the aperture. And we do have two things coming out of one aperture, which makes it a little bit bigger. And when people gain a little bit of weight, they also get some increased abdominal pressure. So these are things that can lead to a prolapse. And, if your long-term goal is a reversal and, you don't want to sort of do a revision, then we talk to people like Andrea to help us manage this. So what are your tricks for managing this type of thing until a second stage operation?
Yeah. So a lot of times when people come, the reason that they'll call us is they'll say, my stomach got huge, or that they'll complain of some pain because at the junction there where that's coming through, it can cause some extra pressure. And so what we do is we bring them in, and first thing is to make sure they can reduce their stoma. To do that, because we just want to make sure that they're safe, that the stoma is going to stay in position, you have them lie flat, absolutely supine, and you want them to look up at the ceiling because it elongates that the abdomen there. And so we teach them just to fold that stoma right back in. Most of the time it can. Sometimes we have to work with it a little bit. Granulated table sugar actually will also reduce a stoma. There's been a couple times that it has been emergent, and so we've packed somebody with table sugar in a huge pouch and sent them over to the emergency department. So, but the big thing is stoma reduction, and they have to wear at all times when they're out of bed. They have to wear a hernia support binder. They need to lie down, reduce their stoma, and put a binder over top of that because we need to hold that so that they don't come out and have any strangulation. And of course, then we have to send them right back to the surgeon. So
never.
yeah.
So, they come to the ER and with the table sugar. And I agree that the reduction and teaching patients to do that is key. And our residents are amazing and really know how to do that well because I've created opportunities for them to learn. So they do reduce it, and sometimes some muscle relaxant in the emergency room will also help that go back in. And that's how we temporize it. If it's something that you think is going to be more permanent, then some of the issues I brought up before, like a risk factor for prolapse and needing bowel fixation, would be to create a retroperitoneal tunnel during the time of the operation. That would be sort of like in the original sugar baker fashion to bring that up, that ostomy up. And that's when you're saying hey, if I'm not going to reverse this ostomy, or if it is permanent and they have prolapse, then you're going to want to think about, you're getting to a stage where you can do an elective hernia repair for that prolapse, or I'm sort of assuming there's a hernia component to it, or do some retroperitoneal fixation or fixation with some mesh. So long-term goals are to temporize this until the reversal or surgical revision if it's going to be a permanent ostomy. Peristomal abscesses and fistulas. These are often an early complication if there's contamination during the surgery, but often can be a later complication in the setting of Crohn's disease. The last person, I had two people with this. One was a Crohn's patient, and another was a person who developed a fistula from the stoma outside, the part that was outside the skin, but it fistulized over after an emergency surgery and went back for revision. So if they have an abscess and a fistula, you want to sort of evaluate that. And your goals with that is to say, is it coming from a fistula or from the stoma itself? If it's coming from the stoma, what part of the stoma, how proximal is it from where it's coming out of the skin if you can't see it readily? And is it coming from an intra-abdominal source, maybe not from the stoma itself, but from another abscess or another problem? So that's going to maybe involve some imaging and endoscopy to figure out where that's coming from. If it's coming from an intra-abdominal source, then you're going to figure out the best way to drain that, be it interventional radiology or a surgical intervention. If it's more superficial and coming from close to the top of the stoma, or is an abscess that you can manage contamination, I think the important part here is that you want to do your drainage outside of the pouching area. So we sort of think of two options. If there's like an abscess or a fistula here, and there's not like a real abdominal component you have to address, you can either ask IR if they can place a drain, and it just make sure they're sort of placing it up by that wafer. If you're going to do it in the operating room because maybe you need to do some debridement or there's other concerns you have going on, then you'll see us make incisions or sometimes hockey stick shaped incisions or incisions. Again, that's going to be outside the area where that wafer is going to sit. And then we're going to enter the cavity, really do a washout and debridement, and often leave some Penrose or drain in place. If you see that drainage is really coming out of the mucocutaneous junction, we may just open that up more. If we don't have a concern that we have like some necrotizing infection or something, we have to really do a significant debridement on, and maybe just open that up and provide a little drainage there. I don't know, Andrew, if you have other suggestions for this problem.
So yeah, I mean, it just after we know how it's going to be medically managed, sometimes you just have to get people through this. And so, if this is something that we had to pouch around, they make actually advanced skin protectants that will, for an extended period of time, protect any exposed skin. So we do a lot of that, or 2-piece pouching systems where they can take the outer pouch off and then recrust several times a day just to protect the skin so that, we can still manage until a surgical intervention's been completed. So
yeah, and it's all sort of about working with your woundostomy team, because all of the sort of specialized wound care for each type of person are just really unique to the type of problem we're treating. Retraction stenosis, this is another patient Andrea and I share. Rachel is a woman morbidly obese and unfortunately diagnosed with rectal cancer in 2021. She underwent the total neoadjuvant treatment. She got radiation and chemotherapy beforehand, but then unfortunately lost to follow-up due to mental health issues, lots of psychiatric hospital admissions and suicide attempts, and didn't come back to see us again until 2 years after she completed treatment. When she completed treatment, she did not have a complete response to rectal cancer, and so she started to have some regrowth there. And she came in with an obstruction, and she needed to go for a diverting ostomy. And this was a diverting lumpectomy that my partner did, and I came in to also, support her through that. She had a very thick abdominal wall. This was a lumpectomy, and the one itself was just so distended with stool. It's just very hard to navigate and touch. But we did bring up an ostomy, and it was really at skin level. And of course, it started to retract and fall in at that time. And at the time that this was happening, she was booked for a pelvic exoneration. We were also trying to manage her for a short period of time until we could get her to surgery. And so with retraction, I think it depends on and stenosis, it depends on what your next steps are and sort of the extent of it. So if we see people early enough, like from a surgical side, we'll teach them to do some hair dilation of the office, make sure that there still is thick enough that it's also helping extend the area open without being so hard that it's going to cause a blockage in and of itself. So some dietary management, fiber management, and we'll have them buy a hair dilator on Amazon and then bring it in so that Andrea can sort of continue to go through with them how to use it. Do you have other suggestions, Andrea, for managing?
Another thing that when somebody gets, has stenosis, especially to this extent, this stoma, Dr. Shanker was able to make actually a beautiful stoma for her, at bedside. But for her, we want to keep them in a convex barrier because that convexity kind of puts just a little bit of tension at the junction so that, because you can see that, that was a wound, that big separation there, and it healed and actually epithelialized. Then that scar is much more rigid than her abdomen. So, Dr. Shanker was able to take all that, and now she's dilating. We still have her do it every day. Just we want to keep this stoma nice and open. She knows how to do it, and she's doing great. She only comes in once a month, I think, just for checks, and she's doing wonderfully.
Yeah, yeah. It's about the level of the skin. And Andrea's right. I did take the skin off. At the time, her surgery was 2 weeks away. And so I numbed her up and we did like a procedure in the office. I just went to see the extent of it first and open it up. And then I was able to suture again to like a new mucocutaneous junction. And that provided her enough with the surface that the patient could see and dilate. And she lost a little bit of weight. Unfortunately, she had tumor regrowth and went through more chemotherapy, which is why Andrea's saying the stoma is still doing well. Now she is booked for next month, so we'll see how that goes for her. But yeah, the convex barrier is a key point, and like doing home dilation. So this is a patient who now in the center picture here, you can sort of see the sort of extent of her like abdominal adiposity. So this is like a previous midline scar, and this is the lower portion of her abdomen. So this patient, Angelica, had a J pouch remotely that was open and then was developing a lot of like pain and symptoms and wanted a diverting ostomy. Had a very complex surgery where they went to give her a loop ostomy, and so it was a loop, but part of like the part they matured actually ended up being the venting end, and the side that was working had pooped underneath her skin. So she got fecal contamination underneath the skin. So they took her back to the operating room to repair that, but you can see not only did she require a wide debridement, but the stoma still wasn't reaching like above the level of her skin, even the working side. So they had to use a lot of Foley captors and things like that to help manage where the stool was coming from. This first, required like lots of sort of wet to dry changes before a vac was being able to be put on it. And so eventually in June, this is what it had looked like. So it's just a stoma like sitting in a crease there, and so for these type of patients, Andrea, where you have just this large abdominal wall, the stoma in a crease, what are your tips for that?
Yeah, what we actually did for Angelica is I had her come in. So for a while until we could get that, and she actually had a wound vac on well into her, after she was discharged home, and she would come in twice a week to have that changed. So we were actually pouching right over top of the back, which actually, believe it or not, was holding her dressing longer because it was pulling all that fluid away that normally would seep up underneath the barrier. But we had her come in, and New Hope Labs makes an alginate mold. So I had her come in, and you can do it over broken skin. So we did a mold after we had 90% healing, and we take that off, and they make a mirror image that barrier will fit exactly into every crease. She was, once we stopped the wound vac, she was changing 4 to 5 times a day, and now she changes her pouch twice a week with that barrier and is doing amazing. So
you like mold it specifically to her. How often do you have to change that mold?
So the great thing about that too is that, Angel has kind of changed shape a little bit. And so we have sent pictures to New Hope, and they have adjusted that barrier for her just based on those photos. And probably the biggest success story I've had with those New Hope custom barriers, because this has changed her life. This woman travels, and it's very her profession requires a lot from her, and she's doing fine now. I think she wondered for a long time how she's going to be able to do it. So we're really excited for her.
Oh, that is, that's amazing. And so do you need a 90% healing rate before you can put those barriers on?
So you can do it over broken skin.
Okay.
Once we have mostly the shape of the abdomen, we can go ahead and do it, because they can just through photos change the level of convexity. Yeah.
Yeah. So it sounds like the vac was helping absorb that fluid, and once it was drier, it was a good time. Yeah.
Yep. Yeah.
Candace was a woman who had metastatic cancer at her stoma site. She was a person who had a obstructing cancer. I'm just making sure we're staying on time. Obstructing cancer. Her completion surgery was ultimately delayed. The plan was to give her a diverting lobostomy, and then she was going to come to me for the definitive surgery, but she coded on the table. So from the time she was diagnosed with the cancer to the time she got her definitive surgery after being evaluated by cardiology and being cleared to go ahead with surgery, she ended up, from her frailty, getting sort of a Hartman's type procedure, endostomy. And then she had some folliculitis metastasis, like at the stoma site. So for her, she got radiation treatment. So you can see she's also a little bit in a crease here. Her body had also changed shape a little bit. And I think that crease bothered her. I think Annika mostly had taken care of her, one of her other amazing wound ostomy team members. And so the radiation did great, I think, from the ostomy point of view, but I think from the cancer and all her other treatments, I think she has just some chronic pain in that area. She still has cancer on the inside around that area too. And so I think we talked a lot about these dermatologic problems. Is there anything else you would add?
Yeah, one thing that we've noticed a couple of times. So with Candace, the last one, she did start radiation again, and she has appears like she could have a little bit of a radiation burn. And so what we did is we mixed Meta Honey with Stoma adhesive paste and used it, and it cleared it right up.
Wow.
So inflammation is also, those burns are really, really hard, and they can happen spontaneously next year. So, but we're finding just focus on inflammation, and it really does help that skin.
Okay. All right.
Yeah.
All right. So finally, we have sort of the top of my my screen from the Zoom is blocking everything, but you have sort of early complications that can be emergent or non-emergent, such as retraction and necrosis, so some of the things that we covered today, and the non-emergent dermatologic being the majority, I think, of what we see. We talked about like identifying congestion or ischemia and the extent of the ischemia, and we've talked about mucocutaneous separation, again, the extent of that. Late complications, again, emergent, urgent or non-emergent. A stoma hernia or retraction or stenosis becomes emergent if it's causing an obstruction. Non-emergent, again, retraction and stenosis with the dilators and the pouching systems. Stoma hernia, again, wearing that, or prolapse, wearing that belt helps all the time. Those are all things that we want to think about. Some other things are just some issues that require maybe not always local treatment. So, for example, stoma varices. If you have a person with bleeding varices, you can immediately address the issue with pressure, epinephrine-soaked gauze. Sometimes like a stitch may work, but not always. But they really need an evaluation of the cause of their varices and addressing that underlying cause. Pyoderma gangrenosum, while we didn't talk about that in detail today, first is a lot of like topical local wound care, but really understanding that this usually is reflecting disease activity of Crohn's disease and understanding what their treatment is for that. And knowing that reciting or looping the stoma will likely cause the same problem in a new location if we're not treating the underlying cause. Stoma fistulas and abscesses, we talked about like how we drain those and how we care for the skin. Metastatic disease and the radiation burn, which is great to think about ways you can provide local skin care for burn. And skin irritation can be, what the patient's doing, comorbid factors, having that appropriate appliance. All those things are good to think about and talk to your wound ostomy nurse about. Any other final thoughts, Andrea?
I guess just I have done this with Dr. Shanker before, and she focused on a couple of things that I've really learned a lot in the past. And one is that, ostomates need to be independent if at all possible. We get so many people that come in and they have their parents or their spouse pouching them. it's a lot harder for the patient to actually understand they need to manage this and they need to be able to manage the wound. So we really, really, really like to get patients independent and managing all these complications themselves. So it's a new goal.
Yeah, yeah.
Yeah.
I mean, I think even though it's not the focus of our conversation today, the mental health aspect of it and the impact on like all the relationships and it re-engaging in society is just really important that they see that they have that autonomy with their health care. So
Yeah.
yeah.
Oh, so I apologize, Dr. Shanker, but many, the UOAA has, people are putting out support groups, and we are very excited because this week we have our first Ann Arbor support group. And so we're going to be, the ostomy nurses will be at some of those, but that's a great thing. If there's a local support group, they're going to be able to get hooked up with an ostomy nurse, with a wound ostomy nurse, actually, and that can work directly with a surgeon. So encourage those because we are really doing that there so we can get patients more resources, I guess.
Yeah. I love knowing that. And if you don't have that resource, Andrea has helped me find patients that you've previously taken care of to talk to some of my patients.
Yes.
Who have been afraid to get an ostomy or go through surgery. And all of those patients have found those individual connections extraordinarily helpful.
I agree. Yes.
So sometimes if you don't have that resource, you can help them make a one-on-one connection.
Mm-hmm.
So I think we talked about the patient factors, the type of stomas that are important, considering the obstacles and complications. Early complications, we've talked about retraction, ischemia, mucocutaneous separation, and late complication. For patients with longstanding permanent stomas, a template and documentation can be part of routine care. And, making sure you're probing them, having some standard intake form can really help you know if there's a change. Can also help you communicate with other providers. And I thank everybody for their time.
Thank you very much. Excuse me.
This is great. Thank you both so much. We have some questions for you. Dr. Mulkey is asking, when do you decide on loop ostomy versus endostomy with mucus fistula, and where do you typically bring out your mucus fistula? Is it the second ostomy site through the midline incision?
If I'm doing the end loop, so I'm bringing them both out through the same aperture, which I'm going to do a majority of the time. When I do that, I think I do that a lot with Crohn's disease. So typically if I'm going to plan on reversing somebody in the future after they're in, remission and they're optimized, I don't want to create one anastomosis in the standard fashion, or even in or I don't want to do a CONOS under like an emergent condition. And then, have that anastomosis be created in a more inflamed condition and then bring up another ostomy that has to be, reversed later and have two anastomoses. And what do I do with that loop ostomy? Do I make that like a CONOS? So I think, especially for my Crohn's patient, I think that I want one anastomosis to be made under the most optimal conditions for the patient. I want to make sure they're in full remission, that, they've been completely worked up on medications, on their biologics. And so in that way, I don't want to make an ostomy that may not work. I mean, make a connection that may not work that great. So those are patients where I'm more likely to say I'm going to make one anastomosis, hopefully, and therefore I'll bring things out through the same aperture, and then do the CONOS once they're totally controlled. Especially for those patients, I may do a surgery, but more proximal in the small bowel or in the anal canal, they may still have active disease. So you really want to make sure that you have total disease controlled to the best of your ability, and that's where these multi-disciplinary teams are essential. So that's a time when I would do that. If we're talking like a diverticulitis, a rectal cancer, I'm going to likely do a lobostomy, and I would say, when do I do, there's no hard and fast rule, and you're individualizing to every patient for different reasons. I may be more likely to do a Hartman's if I'm doing like an emergency surgery. The diagnosis may be unknown if I think that the connection may not go well, or their bowel is really full of stool, and even if I divert them, they could still leak a whole bunch of stool into their abdomen. those are like individual patient conditions, that's sort of like assessing at the time. And you know what, there's always more than one right answer, but I think, those emergency surgeries is a little bit like a poker game. You don't know all the cards your patient is holding. And so you're just taking the data you have at that time to make your best decision.
Definitely. Thank you. Dr. Shostak is asking, what are your recommendations to tell people how to remove their ostomy bag? Do you work closely with the home health with patients who are being seen at home? What's the best resources to guide the patients online for pre-op, post-op recommendations?
Andrea, do you want to try that one?
Sure. So yeah, we work very, very closely with home health. Unfortunately, our home health doesn't have an ostomy nurse. So what we do is we bring the patient in, and if a patient has home health, one of the challenges we have is if a patient has home health, but they have a Medicare contract, the contract says that home health has to purchase their product. And so that's sometimes the biggest challenge, is getting the right product based on what home health is ordering. But absolutely, it's very, very important, because we need them often to follow up with product orders and things, as well as, we have always offered for home health to come in also with the patient at that first appointment. Not always possible, but we do offer that. As far as taking the pouch off, I'm so glad you asked that, because that is a big, big thing that we have to teach right away. Is we use some safe solvents and adhesive removers, because the skin gets thin over time, especially if they are having leaking. And so to prevent that adhesive injury, we want them to use an adhesive remover, a safe adhesive remover. Anything that comes from any of the main manufacturers is safe for a stoma or a wound. So did I answer all the questions? Was there another one?
Do you have any resources for online for the patients? Like, do you have any go-to?
Yes. The United Ostomy Association of America has wonderful resources for ostomates. They can hook them up with, a relatively close ostomy clinic and things like that. And sometimes it just takes one appointment. If somebody can just get in for one appointment, they can really hook them up. Online, though, their other big thing is going to be the manufacturers. So they're going to also be very helpful. We work closely with them as well. So
Awesome. Thank you. Dr. Modi is asking, I think, about that very complicated J-pouch patient who had the diverting lobulostomy. How did you manage the wound vac? Like, who changed it? Who was responsible?
All the examples that I showed, that was not my patient, though I rounded and met that patient many times. But yeah, Andrea, right? The wound bag, and in the hospital.
yes.
And actually, in the hospital, while it was the residents, the wound was so complicated. I think we called over to the Cleveland Clinic also, just for some other recommendations. And got many different wound care people in the hospital involved in that care acutely. So I think that it depends on what institution you're working at. But, we, most of us will have access to plastic surgery and hopefully in a tertiary care center to like a wound care nurse or a wound care team. And so in the beginning, we had like multiple opinions on how we were going to manage that. So for the first couple weeks, because I was on call initially, you would have dressings like falling off and just coming off all the time. It took a little bit of trial and error to get the right thing going. And when we started getting some healing, then the vac was able to stay for longer periods of time.
Mm-hmm.
Got it. Yeah. Very challenging. Dr. Wong is asking, what would an ostomy nurse want the surgeon to know?
Oh, gosh, it's hard to say. I mean, and I'm not just saying that because Dr. Shanker's here, but we get very, very good stomas. Our inpatient team will, help as far as marking and things go. They're actually, from my experience, had when it's possible, the stoma's in a good spot. We get lots of instances where it's not. So that's kind of a hard question. I think that, we have good communication and we know what's coming to us. So um, the surgeons also have given us a heads up in advance when they know a patient is going to be getting an ostomy. And that's been helpful to have people come in advance sometimes just to see that, well, to meet us, first of all, because there's a lot of anxiety that comes with that first appointment. But there's so many resources we can give them beforehand so that they're at home learning about this. They know what a stoma looks like, so they're willing to look down at their post-op appointment and things like that. So yeah, I think we have that good communication, but those would be great things to go back and forth with as far as location and just pre-op education.
That's awesome. Are there any different aspects of marking children for ostomy or?
Ooh, that's a great question. Marking is, on an infant, it's going to be easier. And of course, sometimes, that's going to change over time. I actually do not pouch infants. I don't mark infants, and I never have. The products for infants are very, very different. And you really need that specialized care in like a NICU or a nursery setting because very, very different.
Right. Which company makes the custom molds?
It's called New Hope Laboratories, and it's NU and then Hope.
Perfect. And Dr. Wong is asking, is it true that in Europe, people train their ostomies so they can go most of the day without a bag? If so, can we do it too?
Yeah, we do it here. Yes, patients do stoma irrigation. Sometimes it's every other day, sometimes it's every day, but it's only for colostomies and really kind of lower colostomies. So what you do is you basically give yourself an enema through the stoma. It is something. It's a big commitment. So we've had patients who come to us and they really want to do it, and then they find out what's involved and they change their mind. It takes a good couple months to be able to build up. It causes a little bit of discomfort at first. So it takes about an hour every time you do it. So patients have to have an hour of their day that's set aside just for irrigation. And then, yes, they don't even wear a pouch typically. They'll wear just a little cap or a dressing over their stoma.
Yeah, and I would add to that separately, we do some, like, not as a first line, but sometimes people do that type of irrigation if they have like a fecal incontinence to clear out the left side of their colon. They'll there was a Coloplast project for irrigation, and they'll come in with it, and Andrea will just go through with them how they use it. So it's another, when your anal canal is like an ostomy and you don't have control, it's another way to help you with control. But they do make passion pouches for sexual activity and or for exercise or things like that. So they're like caps that you put on a stoma or very, very tiny bags. And so you may not do an entire irrigation, but if your patient's going to plan to be sexually active, they can do like an enema or some irrigation and sort of and then engage in sexual activity or exercise for an hour or so and not worry about having it still come out.
That's awesome. And do you use rods, ostomy rods?
Oh, do we use rods? Every surgeon is a snowflake. One of my partners likes rods and uses rods. I think the data suggests that you don't have to use anything, right? I think that's what the data suggests. And, I'm strengthening my gut muscle to get there. I think a lot of times, to be truthful, a lot of our patients are obese. So when we're struggling to bring up these ostomies, I would be more concerned about retraction or a heavier colon than somebody with a normal BMI. But I would say that one of my partners uses rod. I will most of the time use like a red rubber catheter and have that removed before they leave the hospital, except in very rare instances. One of my partners uses like a dissolvable suture, like a absorbable suture, like a PDF underneath it. I use that once or twice, like as well. And I think that if I have like the right person, I probably not do one at all. Sometimes if the stoma gets like really edematous or swollen, I take it out in less than 24 hours, and it's okay. So I think that everybody uses something different, and we're all affected by the era in which we've trained, right? So, but my most senior wonderful partner that uses the rod, I was trained with the red rubber, but I'm trying to sort of, for the right person, get away with not using anything or removing that within 24 hours. And so, yeah, I think there's a variety of things to use. Obviously, when we're making an ostomy, often it is not in an ideal situation. And so I think it's rare that you get that perfect anatomy that you're like, yeah, I'm going to use nothing on it. But certainly if that happens, or if we're quick to remove it, I think that's the direction I'm going or trying to. So I say.
That sounds great. Well, thank you so much. This was a great and very educational hour. I'm sure everyone who tuned in really appreciates the lecture and problems and solutions together. Thank you for joining us. Have a good night.
Thank you so much.
Bye.
Bye.